Hello, everybody. Welcome, welcome, welcome to our December 2021 summit. So no, there was no sound on those slides, but Casey's going to come on back on and reiterate what they were. But just wanted to first and foremost welcome you all. This is going to be such an exciting 3 days. We have some amazing speakers. These are all incredible mentors from inside the Medslp collective, sharing wonderful case studies, sharing wonderful clinical knowledge with all of you. So thank you for showing up and for being here. I know it's late for us East Coasters and it's crazy mad rush dinner time for West Coasters, but thank you for being here. And I will let Casey introduce Michelle, our first speaker, and also go over some of those ASHA CEU logistics and where to watch. So anyways, thank you all for coming and I hope you enjoy it.
Hey everyone, welcome to our first night of the summit. Before we jump in and get started, I just wanted to let you know if you have any questions, I'm going to put it in the chat. Please email info@medslpcollective.com. Also, I will put the link in if you would like to receive ASHA CEUs for this, where to sign up. And without further ado, I would like to introduce our first speaker tonight, Michelle. She is going to talk about risks of malnutrition and sarcopenia and dysphagia.
Hello, can everyone hear me?
I can hear you.
Okay, let me share the screen and do this. Hello, everybody. So today's, well, I'm going to make something disappear first. Today's first talk is going to be on tools to assess relational risks of malnutrition, sarcopenia, and dysphagia. I hope I put my email in here at some point, but maybe I didn't. I'll share that if I didn't. But my disclosure statements are that financially I receive payment from the Medslp collective for this presentation. I'm an employee of Memorial Hermann Health System. And non-financially, I'm on the speakers board for board certifications for swallowing and swallowing disorders. Start off with a little bit about me. I am a research education coordinator for speech pathology at TIER, and I've been practicing for 24 years. I'm board certified in swallowing and swallowing disorders. I'm an ASHA CE administrator for 2 professional organizations. I enjoy working with clinicians at all levels to advance their practice. And outside of SLP life, I'm a wife, a mom of a child plus a cat, and I enjoy working out. I'm an avid reader and I appreciate poetry and quotes. So we're going to get started by talking about a few definitions, and I'm going to try and cover a lot of material in a short period of time. So if this seems to go fast, I'm happy to send you guys a copy of this post. I will put my email address in the chat when I'm done talking, and you can just screenshot that and send me an email and I will send it to you. So you guys know the definition of dysphagia. I'm not going to really spend time on that one, but malnutrition is a lack of proper nutrition, and it can be caused by several factors, including not having enough to eat, not eating enough of the right things, and being unable to use the food that one does eat, so more problems with digestion. Frailty is a condition of being weak and delicate, and we know that that increases with age, and sarcopenia is a loss of muscle tissue as a part of the natural aging process. So these definitions will come into play in the future slides. So sarcopenia and muscle fibers. So sarcopenia affects type 2, which are your fast twitch fibers more than your type 1 fibers, and the swallowing muscles are heavily composed of type 2 fibers. And so just to give you an idea, a higher proportion of type 1 swallow muscles are the cricopharyngeus, the levator palatine, and the inferior fibers of the lower pharyngeal constrictors, whereas the higher proportion of type 2 muscles are in the myohyoid, the anterior digastric, and the upper pharyngeal constrictors. But what's most important to take away is that dysphagia associated with sarcopenia appears to be more severe than other types of dysphagia. So what are the characteristics of sarcopenia dysphagia? There's an enlarged volume of the pharyngeal lumen. So those are those patients that on instrumental swallow studies, especially on MBSs, they look really wide, like a large whitish space in the pharynx. and that can impact pharyngeal swallowing mechanics and pharyngeal functions. They're more likely to have residue in the vallecula and piriform sinuses, more likely to aspirate, and show reduced maximum superior and anterior displacement of the hyoid bone and thyroid cartilage. In those who are elderly utilizing high resolution manometry, which is a newer area of our field, they'll show weakened pharyngeal contractibility and dysfunction of the upper esophageal sphincter. And when we take into account what we know about aspiration pneumonia, which is that basic science supports that aspiration pneumonia exacerbates muscle breakdown. So those people that already have sarcopenia or who are frail, the more times they get aspiration pneumonia, the more likely they are to further break down muscle in their body while they're fighting the pneumonia process. And so that induces muscle atrophy in the tongue and diaphragm. So how do we go about diagnosing sarcopenic dysphagia? So the important thing to do is use a validated diagnostic algorithm, which I have in a reference article that's linked at the bottom of the slide. But basically, it's sort of like a decision tree. If this, then that, yes, no, what are the factors going in? The hard thing is that a lot of the patients that we see in healthcare come to us with, say, a stroke or some other neurologic injury. And so sarcopenic dysphagia can only truly be diagnosed in a non-neuro case or a non-other cause of dysphagia case. Not to say they can't both co-occur, but it's hard to just diagnose something as sarcopenia when there could be other comorbidities at play. But it's important to utilize imaging data to make this diagnosis, and that age-related decline in swallowing muscle mass happens to the tongue, the geniohyoid, the pharyngeal muscles. And of note, it's more significant in females compared to males in muscle loss in the pharyngeal muscles. So what about dysphagia characteristics? So, this is a nice diagram. It kind of puts a lot of different things at play here. The oral phase decreases in facial strength, mastication strength, tongue pressure, tongue propulsion. So that's when we start, as speech pathologists, start suggesting maybe softer diets or modified diets. And we'll talk about the complications of what that ends up doing. The pharyngeal phase changes because they get delayed laryngeal vestibular closure, increased inspiration, so their breathing, their respiratory rate's going a little bit faster. They do a lot more swallows per bolus, and there's decreased sensation in the pharyngeal region. And then add to that in the upper esophageal phase that there are changes with increased connective tissue, increased hypopharyngeal pressures, decreased secondary esophageal peristalsis, and cricopharyngeal dysfunction. So when we put all those pieces together, it leads to longer feeding times, which increases in pharyngeal residue and increases in aspiration risk. And we all know that our elderly patient population also sometimes, is more likely to be caregiver dependent, more likely to be in a skilled nursing facility for longer periods of time, whether that's for an inpatient rehab stay briefly or for longer term care. And so they need more caregiver time, but we all know that the staffing ratios are actually not ideal. And so kind of sets up a perfect storm. Another area that you can kind of use to assess how the patient is changing is to look at their masseter muscle thickness. And there's a negative association of masseter muscle thickness and oral dysphagia, which makes sense. As your masseter muscles get weaker, you would have more difficulty chewing, longer oral phases. And I don't know if anybody here has ever had dental surgery, but the longer it takes you to chew, the more effort it takes to chew. At some point you give up on finishing a meal, even when you aren't satiated. So that's a problem that leads to weight loss as well. In frail elderly people, the oral phase dysfunction can produce inadequate bolus formation, an oral transit time delay, and large amounts of residue in the oral cavity. There is some research to show that if we can assess this masseter muscle thickness, it may predict swallowing function and dysphagia in the elderly population. Maybe we could play a role in trying to prevent that if we could see the warning signs a little earlier. And there's also an association between tooth loss and masseter muscle thickness. So those edentulous patients were observed to be had significantly smaller masseter muscle thickness than those with dentition, which makes sense because you need your teeth to like break up food and chew it effectively and efficiently. But that the good news is that it can increase with dental implant therapy. However, we do know that sometimes getting dental services for our patients is extremely challenging due to the continuum of care associated with aging. So some other risks associated with aging are that multiple diagnoses lead to more frequent hospitalizations, which leads to iatrogenic disability or injury. So iatrogenic disability is the injury that healthcare indirectly causes to people the longer they're hospitalized. I'd like you to think of it this way. You go into a hospital and you go in for a heart attack, for instance. Well, while they're working you up for the heart attack and before they maybe place stents and they do all these things with you, you're laying in bed. And while you're laying in bed and you're not getting up, you're getting weaker. And so we cause a secondary injury to you. Then maybe we do a blood draw and that leads to a vein being ruptured. So then we cause another injury. So then you lay in bed even longer. So that's what I mean when I say it leads to iatrogenic disability. The more hospitalizations you have leads to polypharmacy, which leads to dry mouth and difficulty swallowing oral meds, which then further compounds itself and leads to esophageal injury and painful swallowing. And then we look at malnutrition and dysphagia in complex residents. We know that that's also that dysphagia is associated with a higher risk of malnutrition. Due to, and there are challenges to overcome. I've already alluded to the staffing issue. The other issue is diet, because sometimes, there's inadequate nutritional intake by nutrient type and inadequate equipment with which to feed patients, like what kind of specialty cups might you need, or specialty plates or specialty spoons, and are those readily available? And if they are readily available, how are they cleaned and how do they get back to the patient? How do they not get lost? And all those kinds of challenges that we face. Patients who are in SNFs are at highest risk of inadequate protein, fiber, liquid, and vitamins D, K, E, folate, magnesium, calcium, potassium, and zinc. That's a lot of very important nutrients. And then we throw into that care quality. So, a lot of the people who are feeding those who are in facilities have insufficient knowledge. They don't understand the things we understand in the background about dysphagia management, about nutrition, about what the ideal situation might be for like compensatory strategies and how to use them with the patient. They have difficulty meeting the dietary preferences of residents. So if someone served you a bunch of food and none of it really appealed to you and you didn't get to select it, you would just choose perhaps not to eat, which then compounds itself further with weight loss. And so those are some challenges. And throw into that the risks of modifying diets. So when we modify a patient's diet, nutritional intake tends to be lower. Part of that is because it doesn't look appealing. And we can consider advocating for pre-molded foods or having kitchens use molds. But those options are typically a little more expensive. And in healthcare organizations that are trying to cut costs, that might not be something that they are willing to look into. Taste and appetite are related to the way we change the diet. It doesn't taste the same when it's been pureed. And that affects appetite. If it's not appealing, it also might not smell the same or might not smell as fresh or as fragrant. Generally, when we make foods softer, we end up adding water to the recipe to smooth it out, to make it more pureed. However, that reduces the nutrient density and that increases satiety. So if I gave you a cup of water before you started your meal right now, then you would get full faster. So if we mix the water into the recipe to make it easier to swallow, we're also going to make that patient get full faster. As you know, thickened liquids lead to dehydration primarily because people just consume less fluids when they're thickened. And research is inconclusive in determining outcomes positive or negative with diet modification. And so that's kind of a soapbox of mine, which is think very, very carefully about how conservative you really want to be in modifying somebody's diet. So how can we combat these risks associated and get to some successful oral intake? We can, use standardized recipes to promote correct analysis for the nutrients that are supposed to be in the diet. We can ask patients for their preferences, which may change with age. I really advocate, especially in patients who have reduced communication, for picture menus so that they can look at photos and tell you what they might be interested in eating or drinking. Work with pharmacy to review their medications and determine if those are all absolutely necessary meds. Work with a registered dietitian to follow weight trends, hydration, amount, and type of food consumed. My sister's an RD, and one thing she always told me about following weight trends is you have to weigh someone at the same time, in the same manner every time you do it. So if you always weigh that person in their bed, you can't change beds, because when you change beds, you have a new calibration. Or you always weigh them in that Hoyer lift, or you always weigh them at, immediately before breakfast, but always keep things the same, because it will impact the accuracy of the weight trend. You know what we do, and for nursing, to follow the day-to-day patient changes in presentation, like how is that patient changing and evolving, and what does their skin integrity look like? Because, as patients increase in getting wounds, then their nutritional needs might change, and that's kind of a snowball effect. We all know how important oral health is, and poor oral health is a risk factor for malnutrition. If you have fewer than 6 occluding pairs of teeth, that's also a risk factor for malnutrition. Full sets of dentures can improve nutritional status in the elderly population. Oral candidiasis can be found in the oral phase, and in fact, I've fees find it in the esophageal. Go all the way down. You can, not in the esophageal, but the pharynx, and although you can find it in the esophageal phase with additional instrumental studies, and so that can make swallowing extremely painful, and then add to that xerostomia, complicating, making everything drier, making it harder to masticate, drier, thicker foods. So what comes first? That's why I did the analogy of the chicken or the egg. It doesn't really matter what all's happening. It just needs to be addressed. And I like to think of us as the discipline that isn't just speech pathologists, but we're problem solvers. And as problem solvers, sometimes we have to kind of reach out and as communication specialists, make team members communicate with each other effectively to advocate for our patients. Because malnutrition increased costs associated with healthcare. And we know that that's something that the world in general, and even the US specifically, is looking at, because we want to reduce healthcare costs. And so, malnutrition leads to this vicious cycle, because you've compromised the immune system because it's not nourished, it doesn't have enough nutrients. So then there's the need for increased nutrition, and then they end up bedbound, and then when you're in the bed, you're higher risk of pneumonia and diarrhea and loss of nutrients. You're also at higher risk of the wounds. So it's this horribly vicious cycle. Malnutrition is often missed during acute hospitalizations, especially for the elderly population. But note that a BMI of less than 23 has a greater risk of mortality. As we age, we actually kind of need to go into aging with a little bit of padding, just to kind of as a protective force, I guess. And below normal MOCA scores are associated with malnutrition. An E10 score greater than 3 was in approximately 30% of participants in this study that took place in New Zealand, and 70% of the study participants had 5 or more medications on board. So working closely with an RD may improve outcomes for both dysphagia and malnutrition. So what else can we do? We've kind of talked about dietary modifications and really making certain that what they're getting is what they should be getting, oral supplements to support their nutrition. If they're on enteral nutrition, it's recommended for those with a functional GI system and associated with better outcomes, and is more physiologic than bowel feeding. So, and GJ tubes should be considered if feeding tubes will be in place for more than 30 days. I was going to say something about enteral nutrition there, and my brain just, I will think about it in a moment, I guess. And then we talked about pharmaceutical review. Okay. So sarcopenia, its prevalence is between 3 and 30% for those who aren't hospitalized, and it's associated with mortality, a sedentary lifestyle, aging, and underlying disease. Its prevalence is 50% in those who are older and in the rehab setting. It's associated with worse clinical outcomes. And, we're all being asked to look at our outcome measures. We're being asked to demonstrate that what we do works to improve patients across the board in terms of communication and swallowing. And if we can make a difference by improving the nutrition they're receiving, even if it's not by improving the swallow that they have, then we might directly impact their ability to perform ADLs and improve their quality of life. So it spreads across other areas. So there's two different types of sarcopenia, iatrogenic and sarcopenia and sarcopenic dysphagia that we're going to talk about here. And as I talked about earlier, iatrogenic is caused by the activities of healthcare providers. And the less activity you have while you're hospitalized leads to muscle mass loss and leads to loss of strength. And so examples of how we might do that: adverse drug reactions, falls in the hospital, pressure ulcers, nosocomial infections, and complications related to surgery. As we know, tongue strength drives initial bolus propulsion. And so we need adequate energy and protein intake. Adequate energy and protein intake leads to increased strength of the tongue. So what are some ways we can improve it or maintain it? We can use devices like the IOB or tongue bulb to palate kinds of devices to measure pressure and give biofeedback to patients. We can use tongue depressors, although it's more subjective. Does the evidence support that any of these tools generalize to improve swallow function? It doesn't appear to be clear yet. We know that we can improve strength, but does strength generalize to improved function? I think that's the question that we're still trying to answer. So some preventative measures from us: we can promote exercises specific to our clinical area of practice to prevent muscle wasting. The EMST, lingual strengthening, masseter strengthening, and pharyngeal strengthening based exercises can all be used to prevent decline and atrophy. We can monitor change over time. We can utilize those outcome measures from hospital admission to hospital admission, or from beginning of stay to end of stay. And we can consider the use of an approach like the McNeil Dysphagia Therapy Program that drives neuroplasticity for strength and function of the swallowing musculature. So I really wanted to mainly get to this part of touching on tools or outcome measures used to complement the clinical picture. Just getting a visual of your patient and what they look like, and using a chart like this one, which you can easily just search on Google Images and get an idea of, are they proportionate for their body weight? Are they tall, are they short, muscular, inactive? Kind of, what does your patient look like? Working with occupational therapy to get an idea of their grip strength, and then looking to see where they fall by gender and by age. Looking at use of the mini nutritional assessment, which I gave you a link to. It's free and readily available through Nestle. It's an 18-item screening tool used to identify older adults who are malnourished or at risk of malnutrition. And then I sent you a link for the Simplified Nutritional Appetite Questionnaire, because man, I tried to reach this author, but that was just too challenging for me. But I will tell you that it's a very short questionnaire, and concern is raised with a total score of less than 14 of those marked with a double asterisk, because it's a questionnaire. It has like, I don't know, like 8 questions, but not all of them are in the score, only the ones with the double asterisk. The Barthel Index, which your colleagues in occupational therapy are more likely to use and score, but gives you an idea about how the patient is performing their activities of daily living and how dependent they might be, which will give you an idea of whether sarcopenia or frailty has begun and whether they're at risk of malnutrition. You can supplement that with a cognitive screener or a full cognitive assessment, depending on what your goals of your assessment are. You can use the EAT-10. A score of 3 or higher is abnormal, and it can support some of the things you might see on an instrumental evaluation. You can also include the Yale Swallow protocol and determine where the patient falls, utilizing that for a pass-fail according to their criteria. You can use the TOMAS, which I'm happy to also share a copy of that article if anyone needs it. But you're looking at, I use the saltine cracker because the other item is native to New Zealand and we don't have that in the States. So stick with the saltine cracker for our patient population. Looking at head lifting strength in patients, because head lifting can improve anterior excursion of the larynx and anterior-posterior diameter of the upper esophageal sphincter opening. And so you start with the patient with their chin in the position of this photograph, and then you're going to measure how they fall along that scale. And the results of the head lifting study that was completed was independently associated with dysphagia with aspiration after adjusting for age, sex, place of residence, ADL, and nutritional status. So it's a useful tool for assessing the severity of dysphagia. So I like to sum that up with an ounce of prevention is worth a pound of cure, because what matters most to payer sources is that we reduce the length of stay and we avoid hospital readmission. And how can we do that? When patients are planning for discharge, we kind of have to identify not just those who have dysphagia, but those at risk for malnutrition, and try and look at the patient's resources and what they might have available to them. Can they afford supplements? Is there some way that they can have supplements supplied to them? Who's in their social network who might be able to support them or prepare foods for them or deliver foods for them. And so kind of empower the patient or their caregivers to get the best nutrition that they can. And so when we put it all together, there's lots of moving parts that require a team approach. Although some of the ideas here presented cost money, the overall cost savings from avoiding hospitalization and or increases in cost of care associated with malnutrition, sarcopenia, and dysphagia appear to outweigh those initial costs, though you'll probably have to argue that. And malnutrition may reduce physical and mental function, which are primary goals in rehabilitation medicine. I did it.
You did
All right. Questions. I mean, when you try to cover that much that quickly, questions.
Someone says, do you have an appetite stimulant protocol at your facility? If so, how likely are physicians to place a patient on an appetite stimulant during hospitalization?
Interesting. We don't have a protocol for it. We will suggest it if after we've done the med review, because usually a lot of the meds we're giving are the confounder there, and so if we can eliminate some meds, usually that drives appetite, but if not, then we have started appetite. But I'll tell you this, and my sister's the RD, she'll tell you this: when you don't want to eat, you don't want to eat, and nobody making something look appealing or stimulating you will necessarily change that if food makes you visibly nauseous. So you kind of have to get to the root of what's going on.
All right. I think that's it. That was
Did I
perfect
stop?
timing.
Did I stop
I think-
sharing? I didn't. Okay, I think I did.
Wait, one more.
Oh, tell me.
Who usually diagnoses sarcopenia?
Oh, that's a great question. I would, well, there's the sarcopenia algorithm that it's an article I'm happy to direct people to. I would, in the country that the article comes from in Japan, dysphagia is treated by dentists. So an MD or a dentist probably diagnoses it there. I would argue that in the US, I mean, we should be able to play a role if we follow the algorithm, and we could probably just talk about the algorithm in our documentation to support how we came to that conclusion.
Right. There are a few more in the chat if you want to take
Okay.
a peek.
I will.
All right. Thank you so much, Michelle. So I'm going to introduce our next presenter, Rebecca Flowers. She's going to actually be talking to us about interprofessional practice.
I sure am. Let me see here. Hold on. There we go. All right, and I will try to zoom through as much as I can. All right, so like I said, my name is Rebecca Flowers, and I'm going to be talking about one of my soapboxes, which is interprofessional practice. Let me just get rid of something here. There we go. That's better. So financial, I get payment from the Medslp collective. I don't have any other disclosures at this time. About my sources, a little bit about me. So I graduated from Pitt about 12 and a half years ago. And I worked in a couple of SNFs. I worked in acute care, inpatient rehab, outpatient rehab. I have worked in adults and pediatrics. I like to tell people that basically I have the good problem, which is that I like everything that has to do with our field. So that being said, I find that the best practice happens whenever we're working together. I love the collective because it talks about better together, because we are, but I think a big part of that better together is when we're working with other disciplines. So first thing is we need to talk about what interprofessional practice is, because every time I have a grad student, they're like, oh yeah, I hear about this all the time. It's a huge buzzword. I'm sure everybody's heard it. You hear interdisciplinary, multidisciplinary, transdisciplinary, interprofessional. So interprofessional and interdisciplinary, basically the same thing. Multidisciplinary is not. It's not just a whole bunch of people from different disciplines working together. The sum has to be greater, the whole rather has to be greater than the sum of its parts. So multidisciplinary, if you think about like a clinic, then so I know when I worked in pediatrics, we had a lot of, say when I worked, I still work in pediatrics, but we have a lot of clinics where maybe OT will go in and then PT goes in and then an ENT goes in, and that a lot of people think that's interdisciplinary, but truly that's multidisciplinary, because it's not the whole being greater than the sum, right? So it involves, you have to involve the patient and family. They are integral members of the team. That's really hard, but you have to get out of your silo. And so I know that years ago, I used to work with somebody, and she would always say, oh, speech, or lips to the hips. Sorry, that's not me, when it came to a question about another discipline or something. And I would argue that we need to get away from that, and we need to be moving towards saying, hey, you know what, that is partially me. And I can talk about these things. Michelle's whole, I was geeking out her entire presentation, because it's like, yes, teamwork. when you work together, when you work with the registered dietitian, when you work with the physician, all of a sudden you got this like mind meld and things are going better for the patient. So why do we need it? So bluntly put, people are living now that would not have lived even 5 or 10 years ago, and they're very complex. Also, I mean, I think we can think about COVID right now. Nothing has shown the need for interdisciplinary care more than these teams who are going through the hospital and having to work with these very, very sick patients. Patients need comprehensive care. So for a number of reasons, we have hyperspecialization within the medical field. We see it even within speech, but it's, you know, a million times worse or more concentrated or exaggerated within physicians and specifically that medical field. It's necessary. There are people who need a number of specialists. Maybe they need a pulmonologist and a cardiologist and a gastroenterologist and all the, but what happens is we get more siloed care instead of holistic care, and it affects patient outcomes. So interdisciplinary care promotes more equitable care, which should be kind of what we're aiming for anyway. ASHA is calling for it with good reason. If you look at the Institute of Medicine, I mean, this is years ago now, right? 2010, we're talking about, they are talking about like more complex medicine, near misses, things that happen, the cost and the waste. How many times, I mean, if you even just think about, let's say you're doing your evaluation and you walk in and you're about to ask the patient all the same questions that PT just asked them. What would happen if you guys all asked them together? The patient wouldn't have to answer them a million times. That's one thing. That's a very minor example, but it is an example of if we work together, we're better. So it's shown to be more cost effective. A lot of times there's pushback from employers saying that it's too expensive. We can't have these teams, but actually a really effective team actually improves costs and outcomes. But you have to really talk about what that means. What is an effective team? So Nancaro et al. Really is like the guiding work for this right now. And they, I should say, identify 10 principles. So you've got leadership and management, communication, personal rewards, training, development, appropriate resources and procedures, appropriate skill mix, climate, individual characteristics, clarity of vision, quality and outcomes of care, respecting and understanding roles. That's a lot, right? So leadership and management. That's not necessarily something you can change, but it's something that you can, if you've ever seen, I used to tell one of my favorite coworkers this all the time when he's like, you just made that happen, did you? I said, you know, I like to go with the My Big Fat Greek Wedding principle. If you've never seen that, there's a scene where her mom is talking about the man is the head of the household, but the woman is the neck, and she can turn the head whichever way she wants. I love that. And that's how I often would view myself as an advocate for my patients is, you know, a good team can kind of turn the head of leadership, whichever way is more beneficial for the patients. Communication, that's us. That's what we do. We should be really, really good at this, right? So we need to kind of take the lead on that and say, that's my area of expertise and I'm happy to help with it. Personal rewards, training and development, it's critical. You have to, if you are in leadership, you have to invest in your team. If you're not in leadership, find ways to invest in your coworkers. Find ways to reward each other. I know we used to have on one of the rehab units that I worked on, we had something called the Sunshine Box. And you would just write a note to somebody, you know, hey, I had a co-treatment with so-and-so today, and it made all the difference for this patient. I really appreciate that. In the Sunshine Box, takes 30 seconds to do, but it recognizes that person, right? And then training and development is critical too. You have to invest in that. Resources and procedures. Again, that's, these are things that we have to push for, right? Skill mix. Now this is a good one because I know, when I started, I had the pleasure of opening a pediatric rehab unit about, oh my gosh, 8 or 9 years ago. I don't even know now, but we worked really hard to make sure. So my expertise was primarily in dysphagia and cognition and acquired language disorders. And so they made sure that the other SLP on the unit was going to have a complementary set of expertise. And so that made such a huge difference. Climate is very important. If you're in a toxic climate, nobody's going to want to make the team work. And then individual characteristics, you've got to be team players. And I apologize, that's my pandemic puppy who just went crazy. It happens. Clarity of vision. So you have to know what you're working towards. You can't just be coming to work every day and just kind of phoning it in and saying, okay, well, another day, another dollar. You have to know what you're working towards. You have to know what your outcomes are, what you're, if you have quality improvement, if you've got process improvement, you need to have clear vision. And then respecting and understanding your roles. I know that the physician and the therapists were on the same level on the high functioning teams that I've worked on. Whenever there's a more hierarchical approach, they don't tend to be as high functioning teams. Like I said, that's a lot. So keep in the back of your mind, don't drive yourself crazy trying to change things that you cannot. Hold on one second. I'm going to text my husband and ask him to get my dog. Good. Sorry about that. So the other part, we've got to have the values and the principles. So honesty, discipline, creativity, humility, and curiosity. I really want to touch on humility here. If there's one thing that I always, whenever I'm teaching, whenever I have a grad student, whenever I'm mentoring younger clinicians, it's the power of being able to say, I don't know. And when you find a high functioning team members will feel very comfortable saying, I don't know. They'll also say, but I know who I can ask, or let me find out for you. Let me do some research. But if you find people who are kind of BSing their way through things, it's probably not a high functioning team, and you probably need to investigate that. Like I said before, you need to have shared goals. You need to have clear roles. So one of the things that I feel like a lot of times, I'm going to backtrack a little bit, we overlap sometimes with OT, and that can, in my experience, sometimes lead to some turf wars. Whereas what we can do is we can treat it as a place to come together. So the way that we kind of approached that at my last place of work is we actually had a meeting where we discussed our roles. And one of the things that I said, because I think turf wars happen when people feel threatened, right? And so one of the things that I said was, what I love about OT, I said, you know what I love about OT is that you guys are like the bridge. You've got PT over here and you've got speech over here, and you guys are like the bridge that holds us together. And that broke down a lot of the barriers that were there. And we started talking and we started defining our roles in terms of cognitive treatment, in terms of dysphagia treatment, because in pediatrics, especially, OTs are involved a lot in feeding. And so we had to determine our roles. We had to have that mutual trust, which is the next thing. We had to respect each other. We had to understand that we were all experts in our own way and respected members of the team. And I said this before, but making patients and families active members of the team is critical because that's why we're there. And that means you need to involve them in communication regularly, in team communication regularly. So it's hard. It is. It's really hard. And it can feel like you're, just banging your head against the wall because it does require buy-in from the entire team. Also, I promise this is water. It's very dry in my house. So the first thing you want to do is you want to find your people. You cannot do teamwork alone, turns out. Find your team. It could even just be one teammate where you start and start talking. And it's not it shouldn't be a big old complaint session. It can be a vent session, that's fine. But once you've vented, you need to figure out what are your shared values. What are you passionate about? Because what you're passionate about is what you're going to be able to do, and you're not going to be able to let go of it. You'll be like a dog with a bone, right? What are your goals? So once you've identified a workable goal, that's critical, a measurable goal. Once you do that, figure it out. So I love fishbone analysis for this, just because it helps to kind of break down. You've got your problem. I'm pointing at the screen like you guys can see. So you've got your problem. Whoops. And that can seem insurmountable sometimes. But in a fishbone analysis, and this is just an example, you can have so many fishbones coming off of this. You've got, this is a good example. You've got resources and materials as barriers. So these are all your barriers, right? The facility, people, policies. So what do we do about those? What can we change? What is within our control? So let's say policies, for example, maybe the problem that you've identified, there's no policy for it. Well, can we write a policy? Sure. How do we do that? Who writes the policy? Who approves that? And those are all things you're going to kind of flesh out underneath that, within that fishbone. So resources and materials, what do we already have? What do we still need? How much does it cost? Really, really fleshing out the nitty gritty of it so that and you've got a good plan going forward and you've got a good idea of what your barriers are and how you can address them. So what does this look like? So inpatient rehab is what I'm most familiar with, and I feel like it's a place where interdisciplinary work can really thrive because automatically you have PT, OT, speech, you might have dietary, you've got the physiatrist, you have, oh my gosh, you've got respiratory therapy, you've got all these people, right? You've got psychology. I know in pediatrics, we had child life, we had the recreational therapist, so many people, right? So a way that this can work there is, so one of the things we did with our really complex patients is we did a fishbone analysis for what was most difficult. And nursing identified that learning how to feed them and how to transfer them was really difficult. Well, that's not even something that we necessarily knew they were having trouble with until we sat down as a team and discussed it. So let's say in a SNF, you could have functional cognitive treatment. Well, what does that look like? Could that be speech and OT, or could that be speech and PT working together? I know that I work together with PTs frequently when I worked in skilled nursing facilities, and because I wanted to see if this person's going home, what does it look like when they're dual tasking? What does it look like when they're dividing their attention and all of a sudden, they're walking with their cane and they look great walking with their cane, right? When they're in the gym, and they're really focused, they've got that cane and they're walking. All of a sudden I start talking to them and they're gesticulating with the cane. It's like, no. So that can be a functional cognitive treatment, which you wouldn't have been able to do without that co-treat. And again, that's where the sum or the whole is greater than the sum of the parts. I really want to say that wrong. But that's really, really critical to think about. PT would not have known that that person was unsafe without our intervention. And we would not have known that that person was unsafe without PT's intervention. So we learned something more and the patient benefited because of it. In outpatient, co-treatments can be so great. One of the things that I often say when I'm teaching about cognitive therapy is get out of the clinic, get out of the room, get out of your office. Once the person has shown that they can do things in there, great. That's not the real world. So who can we co-treat with? Where can we go? Is your outpatient clinic in a hospital? Can you go to the gift shop? Can you go to the coffee shop? Can you practice walking with PT while they find where their appointments are? Can you go and have them practice, talking to the front desk or, navigating, that kind of thing. So the co-treatments are so, so great in outpatient. In acute care, a really, really good example is the trach team, right? If you have a high functioning trach team, it is so incredibly valuable. It makes such a difference for those patients. So what I kind of challenge all of you to do is think about how this applies to your setting, because everybody's setting is different and everybody's culture is different. Everybody's coworkers are a little bit different. And so it's never going to be one size fits all, but you can think about it and I guarantee you can find some way to make this work in your setting. So moving forward, I want you to, I'm so sorry about this dog, guys. Think back to the principles from earlier. Which ones can you effectively approach in your setting? So maybe you're on a continuing ed team or on a continuing ed committee. Can you apply that to personal rewards training and development? Can you say, hey, it might be really nice to get some training on interdisciplinary care, or it might be really nice if speech and OT sat in on PT's continuing ed sessions so they could have some idea of what they're doing, and vice versa. It might be really nice if we all did continuing ed together. Wouldn't that be nice? I know that we did that, and I would do them on some pretty simple like AAC stuff and things like that. And people loved it because they got to learn things that they never would have known before. For an example of this is every SLP on the rehab unit where I worked was transfer trained, was trained to walk with patients. We were trained to ambulate with patients. We were trained with the gait belts. We were trained with the walkers. And that is not a thing we learn in grad school, right? And that can be a little scary at first until you realize that you have to trust your coworker that he or she is going to train you appropriately. So maybe that's a thing that you are on, a committee, and you can work on that. The climate, that's hard, but it's doable. Can you start going out for happy hour once a month? Can you kill two birds with one stone and have said happy hour also be a journal club? Can you, start having silly little things like, not just, I feel like everybody celebrates birthdays, but, having things like remembering when PT month is, when OT month is, when better hearing and speech month is. I feel like we know those ones what can we do for Nurses Week? What can we do for Respiratory Therapy Week? Things like that, so that people feel appreciated and it improves the climate, right? Clarity of vision, that can go back to what we were talking about with the fishbone analysis before. That is so important to have that clear vision. And it needs to be focused too, because it's really easy to get bogged down in, well, there's so much to do. There's so many problems, I don't even know where to start. It's me walking into one of my children's bedrooms and going, oh my God, they're so dirty, I don't even know where to start, right? So I have to say, okay, I'm going to pick up the dirty clothes first. That's not true. I make them do it now, but still. But you have to say, okay, what can I control? How can I turn that into a goal? How can we turn that into our vision? And how can we work towards it? And that's when you're going to want to look at your outcomes. And you really, I cannot stress enough how important it is that you respect and understand the roles of your coworkers. If you do not have mutual respect, you're not going to go anywhere. Period. End of story. And that can be uncomfortable too. I have people with whom I'm still very close friends, who I've had, for lack of a better term, come to Jesus meetings with them because I'm like, we are not on the same page with this patient. We need to talk and we need to hash it out and we need to figure it out, because it's what's right for the patient. Doesn't mean that it ends in a screaming match, but it does mean that we kind of put it all out there on the table, but we respect each other enough to do that, to not take it personally, and then to move on, right? I remember I had a rookie mistake one time where I was in a patient's room during a co-treat and I was talking about the patient in the third person. And one of the PTs called me out on it. And I just said, thank you. You should call me out on that, because that's a person. I should be talking to that person, not about them. But, 10 years ago, I would have been incredibly defensive and offended by that. But I realized that PT who said that to me was coming at it because he knew me and he knew that wasn't who I was. And he knew that the patient deserved better. So I think, I managed to leave a couple minutes for questions. I would love to take some if we have any.
We do.
Sweet. I'm gonna stop sharing. All right.
How do we advocate for co-treating an outpatient when we both can't bill for the same time? I know that would be a pushback from my facility.
So the way that we've managed, so I work in a couple of outpatient clinics right now, and the way that we've managed to kind of get around that is that, and I know that our billing people have looked into this a lot, is that PT and OT are timed and we are untimed. And so we bill for untimed minutes and they bill for timed minutes. Now, if PT and OT co-treat, they have to share the time. But as long as we bill for untimed minutes, we've been okay. Unless we're doing cognitive therapy, and then it's a little bit different because that's a timed code. But if we're doing language therapy or we're doing feeding therapies, things like that, we can do untimed codes for that.
How can we move forward when our leadership is the problem and administration won't do anything about it?
Oh, I wish I had a magic bullet for that. I really do. I actually recently left a position for this reason. But it doesn't mean that you shouldn't fight the good fight, and you shouldn't give up. Like I didn't give up. I still actually work with that group of people and advocate for the teamwork that is so important. So the short answer that I can give you to that, because we only have a few minutes, is get to know leadership and make them get to know you. It's easier said than done. It's a long game kind of situation. But I remember being in an annual meeting for the whole SLP staff. So there were like, I don't even know, 75, 100 of us there. And one of the vice presidents came up and said, "Hey, Becca." And people were like, "How do you know her? How does she know your name?" I was like, I get to know her. and she knows that I'm good at what I do. And so she respects that. And, I've had phone conversations with her. I've had, what? Like, yeah, it didn't happen yesterday. It happened over the course of years. But yeah, that's the short answer.
We can take one more.
All
Any
right.
suggestions for rural settings and therapists or team members coming and going, rarely seeing each other in person?
Ooh. Well, without knowing all of the barriers, that's hard. But I would say finding a time and making a concerted effort and a very mindful effort to have a time when you guys are all there, even if it's just one time, and you can sit down and do like that fishbone analysis and say, is there a day, like, what's our goal? What's our problem? Our problem is we don't ever see each other, and so we can't do any team stuff. All right. So what are the barriers? Well, I work in outpatient and I work in inpatient and I work in home health and I, that kind of thing. And saying, well, is there a time that we can say this day of the week and these 4 hours are when all of the team members are going to be in the building, that kind of thing. It's easier said than done, but nothing important is easy. So I hope that answers it.
Thank you so
All
much.
right. Thank you.
There are a few questions in the Q&A if you can take a peek at those before you.
I will hop on in.
All right,
Thank you so much.
All right, and on to our third speaker of the night. Welcome, Libby.
All right, good. Yes, good evening. I am going to share my screen and get started. All right. All right, so we're going to talk about person-centered treatment planning in dysarthria. This is a topic we tend to talk a lot about when we get to cognition and aphasia, but it's just as important with dysarthria as it is with the other areas that we serve. Again, I'm Valeria or Libby. My legal name is Valeria Gary, and I'm going to kind of jump ahead here to my disclosures. I receive payment from the Medslp Collective for this presentation and also other roles that I serve there. I'm an employee of Wellstar Health System, currently working in outpatient neuro rehab, and I'm the owner of Southeast Parkinson's Speech Services and Total Body Cognition. I don't have any non-financial disclosures for this presentation. All right, the information has been collected and at least as of November 2021 was considered to be current. A little bit about me. I've been a speech pathologist for over 30 years. I've worked in a large variety of settings, pretty much every adult setting that there is. Outpatient is my love, and that's where I've been for the past 6 years. My claim to fame, my 15 minutes of fame, I once sang with the Temptations at an ASHA convention. My hobby is competitive powerlifting, and I've recently started doing a lot of genealogical studies, and I've traced my paternal ancestry back to Joe Welcome, an enslaved artisan, bricklayer, and stonemason who was born around 1774. All right, so our agenda for this evening is, first of all, we're starting off with the assumption that we all know what person-centered care is and why we need to use it. And we're going to talk about how that plays a part when we do our traditional motor speech evaluations and our treatment plans and approaches for motor speech. But just kind of briefly, when we talk about person-centered care, we're talking about patient and family-centered care that is the result of collaboration and shared decision-making between the patient, family, staff members, clinicians, everyone involved in order to create a customized and comprehensive care plan. Because people don't come to us with the goal of being able to read a list of words with 100% intelligibility. They come to us because there's some type of participation in life that they are not able to do because people have difficulty hearing or understanding them. All right, so when we look at this list here, this is kind of our typical course of events. So, we gather information from the chart review, from talking to the patient, we do our evaluation, we do our differential diagnosis. We're going to make sure we collaborate on an outcome. That's a real big part of what we're going to do talk about tonight. Decide together on approaches. A big part of our decision is going to be looking at our subsystems of speech and figuring out what the patient needs, but also looking at in the real world, how is this going to play out? And then we write our goals. All right, so you see on this part, so the assessment process, there are 2 questions here. And these 2 questions we're going to come back to when we start talking about treatment planning. But the questions are, what does the patient want and why don't they have it? So ultimately, when I'm doing an evaluation, I want to find out, what does the patient want as a result of speech therapy and why don't they have it? What's going on with their system that keeps them from being able to do what they want or need to be able to do? Now, we're going to explore some of these in the next slides. I've got more information on the slides than we could possibly cover in 30 minutes, but I just wanted to have it there for your reference. All right, so our chart review, this is for a lot of us a familiar process. We're trying to get a lot of information about what's going on with the patient. What kind of condition do they have? Is this something where they can get improvement? Is it something neurodegenerative? This gives us our starting point. The prior level and changes, we want to find out for the patient, like, okay, what's different now? Like, why is your speech a concern to you? Why are you here? What was normal for you before? Well, what are your expectations? So for example, was your normal day only talking to a small group of friends and family, or were you teaching a group of students or delivering keynote addresses? Just like, what is that prior level? And we always want to make sure it's a recent prior level, because sometimes patients will give us a very old prior level and we find out they hadn't done that in 10, 15 years. We also want to find out about the patient's dialect or culture, because we don't want to diagnose someone with a motor speech disorder if actually what we're seeing is just a difference in speech production. And then those functional limitations, like, okay, what's working for you? What's not working when it comes to communication? Like, how are these speech problems getting in the way of what you need to be able to do? If therapy works out the way we hope, what are you going to be able to do? Sometimes this is hard for people to give us a really specific thing. They just want to get better and they want to just come to us and find out how to get better. And so sometimes I'll frame it as, okay, so I need to tell your insurance company why you need to come here for therapy. So tell me like what you're struggling with specifically, though we can tell the insurance company she needs to come here for therapy so that she can do X, Y, and Z. I like to start the conversation about what someone's wants and needs are from the very beginning, so that it doesn't come to a surprise when I'm asking them more about their specific goals and asking them to bring in personally relevant materials as part of the therapy process. All right, this is just kind of here for your reference as far as when we do our evaluation, some of the things that are included with that. Also for your reference, we've got some tools. The ones on the left are, I would say, either free or readily accessible for a small amount. The ones on the right are standardized assessments that might cost a little bit more money. If I only had one thing on this whole page, well, I can't speak to the standardized test, but on the left side, if I could only have one thing, it would be the Duffy text, because it goes into such great detail about how to do evaluation, how to do treatment. So I highly recommend that for everyone. The Newcastle Dysarthria assessment tool is more of a protocol. I do not think it's standardized, but it's a protocol that goes through all the like how to evaluate the subsystems of speech and how to do a differential diagnosis. Reading passages are good to have. I almost always use the Caterpillar passage for motor speech evaluations. I have not used the grandfather passage in years, and the rainbow passage I tend to use mostly for voice. But these are, those are freely available. All right, so again, this is information just here for your reference. When we do our evaluation, we're still doing that traditional approach of looking at all the different subsystems and figuring out what is going on with that patient's anatomy and physiology. This person-centered part is what are we going to do about it, and what kind of materials are we going to use. With respiration, if someone has a lot of difficulty with this area, a lot of times this is going to be our starting point, is improving that breath support for speech. When it comes to phonation, this is another one. If there are a lot of deficits in this area, this might be where we need to start our dysarthria treatment. We're looking at, the voice quality, the pitch range, loudness range. And what I like to ask patients is, how do they describe their voice? Because if I use a term that's not familiar to a patient, they may or may not let me know that they don't know what I'm talking about. But if they describe their voice as gravelly, or if they say it sounds like a whisper, that I'm going to use that same thing. I might say, okay, well, we're going to work on this exercise so that your voice doesn't sound as gravelly, or we're going to do this approach so that your voice sounds less of a whisper and more like a louder voice. So always kind of listen into how patients describe things. Now, articulation, again, we're looking at the intelligibility. We're looking at, what are the physical abilities for those articulators, and our differential diagnosis. So, is it dysarthria? And if so, what type? Is it a motor planning problem? Is there an aphasia present? Are we hearing slurred speech? Or are we hearing neologisms? Those are things we want to figure out. And again, find out, how does the patient describe their speech? Do they say slurred or slurry? Whatever words they use, it's helpful to use those words when you're doing education, so you know that they understand what you're talking about. And if you can also give the correct term, you can say, if they have a term that's not familiar to you, you might say, such and such, which I would call, slurred speech, or I would call imprecise. Now, one thing that's real important when we talk about articulation, if you are working with a patient who does not speak the same language as you, there's a high risk of an improper diagnosis. And that's because when we work with interpreters, and the assumption is if your patient does not speak the same language as you, you're using a qualified trained professional interpreter. And even though someone's a qualified trained professional interpreter, it does not mean that they are prepared to help out with a speech therapy evaluation. An interpreter's job is to take the meaning of what one person says and translate it into another language, and it's based on that meaning. So the interpreter does not necessarily listen out for types of errors or types of sound substitutions. They're not looking at the motor planning. They're figuring out what the person's trying to say, and they're conveying it to you. So when you work with an interpreter, it's helpful at the start of that session to explain to them what you're doing, what you're looking for, and asking questions like, okay, does it sound crisp and clear? Are they using the right sounds? The words, is that the right word for what they want to say, or is there a better word that that would typically be said? Let's say, for example, it's Spanish. Okay, where's the patient from? Because there are different Spanish dialects, for example. Is the interpreter knowledgeable about that patient's dialect? So again, we really want to be extra careful. In an ideal world, we would use bilingual SLPs to do these evaluations, just like we would like to do that with aphasia and cognition. But when we can't, we have to make sure that we're giving the patient that best possible service. Now, when it comes to residents, again, these are some of the tasks that I tend to do, kind of looking at hypo and hypernasality. And then prosody. Again, for your reference, I like to ask people, how do they describe the sound of their speech or the sound of their voice? Sometimes people will say, I sound like a robot. And so again, kind of use that terminology when we're doing our education. Now with prosody, sometimes we think of this as a fine-tuning thing. We think about, getting someone's speech clear first and then adding intonation, making it sound more natural. But there are times when prosody actually needs to be one of the first things we do, because if someone, for example, is speaking at a very fast rate, and we find that slowing their rate makes them more intelligible, in a situation like that, prosody is going to be one of our earlier things to address. Okay. Now, patient-reported outcomes. These are going to be the measures that you have a ranking system of different life participation things, where the patient rates how much difficulty they're currently having with those areas. I absolutely love using these because, for one thing, it opens up a great conversation. So if someone just has a vague idea that they just want to sound clearer, but they aren't able to tell me like what the settings are, like what type of treatment activities are important for them to do, we can go through that patient-reported outcome measure, and I'll look and see like areas where they rate it low as far as low ability, and I can say, oh, I noticed you have more difficulty on the phone or in a conversation where there's more than one person. Is that something important to you? Should we practice that in therapy? And you can get that information from these. These are all freely available, the ones that I have listed here. This is not to say that these are the only ones that are available, but these are ones that I've used, and like I said, they're free. Okay. All right, so differential diagnosis. So we do the evaluation, we've assessed all the different parts, the subsystems of speech. We've talked to the patient to find out why they're there and what their concerns are. And now we're trying to figure out what are we going to do. So first we have to figure out, first of all, is it dysarthria? And it's helpful to know if it's dysarthria, what type. And like, does everything match up? Like when we see in the chart, the medical history in the chart, does that match what we're hearing with our speech? Sometimes we see things that don't quite match up. We see one thing in the medical chart and we're expecting something else, but the patient has a different presentation. So we're just pulling all this information together. We're asking, is it apraxia? Is there an aphasia present? Is it neurogenic stuttering? Is it none of the above? Is it a combination? You know, sometimes people come in with more than one speech disorder. So we're trying to tease apart what's what and what our priorities are. So again, it's important to know what you're working with. There are lots of resources online and textbooks to help you to distinguish between, for example, dysarthria versus apraxia, or apraxia versus aphasia. And again, if your patient speaks a different language from you, there's a high risk of misdiagnosis. So really, really important to make sure you're getting accurate information. So to kind of like recap our evaluation process, evaluation, we're still following our standard protocols, emphasizing the patient's goals and functional limitations. We might step away from some of the standardized protocols and do something really functional for the patient. So maybe having them do some non-standardized tests like divided attention, or making a phone call, or maybe we're on the other end of the phone call and listening to see how intelligible they are. It's perfectly great to do those things during evaluation, because then we've got a baseline and we can create a goal around that if that's important to the patient. All right, a word about functional motor speech disorders. When it comes to as far as like how we're doing the evaluations and how we're doing the treatment, we're still working based on those subsystems of speech. The difference with functional motor speech disorders is that there's a bigger counseling component to it. And there's also the good news that there aren't any neurological barriers to that patient achieving clear speech. So we expect to have a faster outcome with our functional motor speech disorders. If you haven't already, I highly recommend the course on MedBridge called Diagnosis and Management of Acquired Functional Speech Disorders. Excellent course. It helps with differential diagnosis and with treatment planning. All right, so we see things like this photo a lot online when we're looking for inspiration. Set a goal, make a plan, get to work, stick to it, reach the goal, and you're going to be happy. And if it was really that simple, that would be fabulous. We would all just achieve every goal that we have in mind. Now, goal setting for dysarthria might be a little bit less challenging than it is for aphasia, because motor speech is a little bit more concrete than, for example, aphasia or cognition. But still, people are complex. Medical conditions are complex. So, in therapy, we pretty much have to do the evaluation and boom, set that goal right away. That's usually our first step. The problem with that sometimes is that we make the plan, but the patient doesn't, quote unquote, get to work and stick to it, and we're not sure why. And sometimes it's because we've gotten ahead of the patient. The patient has a goal of wanting to get better and have clear speech, but maybe they haven't actually committed to the actual changes that they need to do in order to reach that goal. They haven't committed to changing the way that they talk, or they haven't fully committed to doing daily practice with their speech exercises when they get home. So those are some things that kind of get in the way of that nice little inspiration of how to get to your goal. So one thing that we're going to talk about as far as some techniques to use if we do have a breakdown in that. But again, so setting our goal, sometimes that's easy. Sometimes the patient tells us, I'm a teacher. I've got to be able to speak for 6 hours a day and be clear over noise. Other times it's a little bit more vague. So it might take a few conversations to really find out what somebody needs. But I always stress that. I tell people, I don't want to just practice a random list of phrases with you. I want to practice the words that you really need to have come out of your mouth clearly on a regular basis. Right. All right, so some food for thought. So when it comes to that goal setting conversation, remember, patients don't know what to expect. If they haven't had a stroke or rehab before, they're coming to us not knowing that we're wanting them to be an active participant in that treatment planning. That traditional medical model where I tell you, you come to me, I tell you what to do, you do it, and everything's done. That is a model that a lot of people are expecting, and some people are still practicing that. So again, if someone doesn't have experience with a clinician who is really working towards person-centered care, they might be just expecting someone just to tell them what to do. Patient's goal is usually normal. Like why would I be coming here? Otherwise, I want to be normal. That's my goal. Have the conversation. It might take sometimes more than one session. We still have to have our goals on day one, but as far as really figuring out what treatment materials, what treatment exercises we're going to do, sometimes we might have to take more sessions to really get that from the patient. Sometimes we might get resistance. Some people just want to say, just tell me what to do and I'll do it. I don't want to initiate bringing anything in from home. I don't want to really talk about my hobbies. I just want to do some exercises and be done with it. And then keep in mind that eliciting those person-centered goals, it's a skill that comes with practice. All right, just a reminder of our evidence-based medical triad: best available evidence, patient values, and clinical expertise, with patient values being equally important. All right, so talking about the treatment decision process. So we go back to those first two questions. What does the patient want and why don't they have it? So one thing we want to do is find out what the patient wants, and we want to get that into some type of a specific and measurable goal. So we've gathered all of the information from the results, the goals, the complaints, medical history, information from the PROMs, and we're going to help the patient formulate at least the specific and measurable part of their SMART goals. So with that, I'm asking, what do you actually want to be able to do? So not just, I want to speak clearly, but what are you going to do with that clear speech? Do you want to be able to call the kitchen and complain about your meal? Do you want to be able to clearly pronounce the names of your medication? Do you want to speak for yourself at medical appointments? Do you want to do story time for a group of kindergartners? What is it going to do with this skill that we're working on? That's what we need to practice over the course of our therapy. What's your highest priority? And again, you can use those patient outcome measures as to give you some conversational things. Now, let's say you asked, and sometimes people say, I still don't know what my priority is. I just want to get better. I can't help you out. I can't tell you what I want. So these tips are not just for dysarthria, but also anytime someone's goal is kind of normal. All right. There are some resources on the Medical SLP Collective for motivational interviewing and goal attainment scaling. And there's discussion about shared decision-making and self-anchored rating skills within those two resources. But motivational interviewing, that's that collaborative conversation with the patient, the family, the clinicians, based on 4 key skills of asking open-ended questions, doing affirmations, reflections, summaries, and then our methods: engaging, focusing, evoking, and planning. Okay. I do want to spend some time talking about goal attainment scaling. So this is a ranking system for goals. And one of the benefits is that this helps to the patients to establish a good sequence of goals. So we get a clear behaviors with them, and we can figure out what our targets are. So this starts with that -1, which is the current status. So maybe the patient is 50% intelligible at the sentence level. So then we say, okay, what would happen if things got worse? So things got worse. Let's think about the day of the stroke or the day after the stroke. So maybe they were just 50% intelligible, period. So not just even single words. Then for our 0, our acceptable level, it's like, what's just good enough that you don't need therapy? So maybe it's decided that there's some functional phrases that the patient can say. The family is able to understand them 100% of the time, but maybe they have to use some supports and some strategies for that to happen. So maybe like an alphabet board as you're doing these conversational things with the family, but the family can understand them. Then our +1, better than expected. So maybe in this case, the patient might say, okay, well, 100% clear in a quiet environment, and I don't have to use that alphabet board. Like maybe I have to slow down. I have to have the quiet, but I can be understood all the time. And then the best it can get, it might be, I'm 100% intelligible over the telephone. If there's background noise, people are understanding what I'm saying the first time I say it. Now, with shared decision-making, this is another tool to help people to come up with those specific goals. Again, it's a collaborative conversation. We've got 3 steps to it. There's team talk, where we're all talking, nursing staff, family, patient, trying to figure out what's going to be the best course for this patient. 2, letting the patient and the family know what their options are. So people always have choices. It's not only what we think is best. And then the 3rd one is the decision talk. So making decisions together. And that's where we want to really make sure we're avoiding what's called the writing reflex. And that's the the tendency as a care provider to say, I know what's best for you, and I'm going to tell you what to do. And if you don't do what I say, then you're really going down a bad path. Okay. Now this slide, if you have the handouts that were done ahead of time, this slide is not on there because there was it got deleted. But self-anchored rating scales, very similar to our goal attainment scaling. So we're looking at a continuum based on the patient's perception of their abilities. So we're asking, like, what was communication like before today? And that before today meaning, like, that initial after the stroke or the head injury or whatever the onset is. And we're using that as the anchor. We're using that as our comparison point. We have a line, which you'll see on the next slide. 0 is no ability, and 10 is good enough that you don't need therapy. And so then we'll ask the patient, okay, what will communication look like when you don't need to come to therapy anymore? And that sets up a conversation that is not about complete recovery. It takes us to a shorter point. Then we ask, what does communication look like now? Or what would a little improvement look like? That's going to get us to that short-term goal. And then when have you been successful with communication? That's going to help us to figure out what strategies that the patient has found helpful. So here's an example of the line. So we have, for this patient, the 10 is going to be, just good enough where I don't need therapy. I'm understood at home, when I'm going through the drive-through, and when I'm on the telephone. And this is based on a conversation I had with a patient. And so I said, well, tell me more, like what's understood? How do you know when you're understood? And he's like, well, I won't have to repeat myself. When I make calls, I won't get hung up on. And when I go through the drive-through, I'll get the right order because they understood me. Right? And then we might talk about, okay, so where are you today? Okay, maybe, or where were you when you first started after your stroke? Okay, that was a 2 or 3. Where are you today? It's a 5. All right, so what's a 7? Like, what can we do to get you a little closer to that 10, but not all the way up there? And so this one will be, well, my spouse and kids can understand me. And when I go to my favorite restaurant, they're able to understand when I'm placing my order. Okay. All right, so with person-centered care, I also want to talk about sometimes what the person is asking us for, it doesn't really go with what we feel should be done. So what do we do if someone, they read something on the internet, they heard about some exercises, and these are some non-speech oral motor exercises, which we know the evidence does not support using in order to improve speech. But they come to us and they say, this is what I want. I read about this. What do we do? Well, I used to kind of like to be the big naysayer, and I would tell them why we shouldn't do that. And I would launch right into like, oh no, that's not a good idea because there's no evidence behind it, X, Y, Z. But that's not really the best approach for us to use. So this comes from a nutrition program, but these tips apply to us too. So we don't want to be dismissive. We want to start off by giving some positive feedback, like, oh, I'm glad you asked. That's a great question. And I can see why you would, connect those two things together. Or that's great that you're being proactive and you're looking up information ahead of time online. And then you follow that with expressing curiosity. So, what was it that stood out to you about that? What did you, what appealed to you with that approach? Or you might say, I can understand why that appeals to you. Let's talk about why in your situation, that might not be the appropriate approach for us to take. We want to support and not judge them. So sometimes people they like the exercises because it seems more specific than when we give them like a 5-minute speaking task to do at home, or like reading out loud and retelling it. So we might say, okay, well, I see that you like the structure of having some exercises. What if we did something a little bit differently? Like, what if I structured our practice using methods that I'm confident will work better, but we'll make it look more like those exercise sessions. So maybe I'll give you a number of times to do something and a number of sets instead of saying like a 5-minute passage. And we still might end up with a 5-minute passage, but we've structured it because that's really what the patient was looking for, just something they could kind of sit and know that they've done completely. And then, we try to get the patient to try things objectively. So we're, giving them a strategy to use, have them try it out in the real world and see what kind of reactions do they get from people as a result of doing that. They have more successful. All right, so what the patient wants, and then why don't they have it? Again, this is like, what are we going to target in our therapy? So we're looking at what's that physiological barrier to the patient's desired outcome. So like whatever the impairments are, if we address them, which would have that biggest impact. We look at things like first order, second order, third order, as far as like working on respiration and resonance, phonation, articulation, and porosity. So this is the same as our traditional tasks. I've got here a list of different protocols and procedures that we can use for our treatment. The standardized ones, one thing I like is that they all have some carryover type activities. They have functional phrases that are very helpful. Definitely want to talk about divided attention. As Rebecca mentioned her talk, it's not just about what someone can do sitting across the table from us in a quiet setting. So we definitely need to be doing divided attention tasks when we're doing motor speech, because we're talking about real world activities. So that's walking and talking, or doing ADLs and talking, thinking quickly and talking, having a multi-partner conversation, abstract thinking and talking. It doesn't have to be that they're at the conversational level to do these, but we always want to make sure that we're making these things, activities, as real world as possible. And then finally, as far as culturally responsive practice, when we're doing assessment and outcome measures, we want to make sure that the diversity in that testing population matches the patient that we're doing it with. Otherwise, we need to note that our results might not be valid. Know the difference between a disorder and a difference. And then open-ended questions, we use that a lot for motivational interviewing, but for some patients, particularly if they are neurodiverse, they might do better with yes/no questions at times. Patients are their experts in their own lives, so allow them to decide what's important for them. And if services are being provided by an SLP who does not speak the same language as the patient, there is a high risk for inappropriate treatment. So a trained professional interpreter, better yet, a bilingual speech pathologist, will reduce the risk of misdiagnosis. There's my contact information. Feel free anytime if you have any questions. I will answer questions after this, but feel free to contact me. And I thank you.
Thank you so much, Libby.
Sure.
All right. So we will wrap up our first night of the summit with Ramya.
Hello, can you hear me?
Yep.
I'm gonna try to share my screen here. So, Casey, can you see just the screen or the presenter view?
I can see just your full slide. So I don't think it's presenter view. I think it's just the screen.
Awesome, perfect. Just get my timer set up here so I don't fall behind. All right. Well, hello, everyone. Thank you for staying late. I'm on the West Coast, so this is just after work for me, but just kind of wrapping up today with a pediatric feeding topic. But like I always say, if you've heard me present before, everything pediatric still does apply to the adult population, because our pediatric kiddos do grow up, believe it or not, and become adults. So sometimes we, or you all that are working with adults, will probably see some of these things downstream as they are growing up and becoming young adults. So it's just always something I think to keep in mind. So today I just wanted to touch a little bit on the role of sensory processing and just the sensory system in pediatric feeding skill development. And so here are my disclosures, and we'll kind of get started over here. So if you have heard me talk before anytime recently, this visual or this slide may be very familiar. And one of the reasons why is I absolutely love that we have this pediatric feeding disorder consensus definition right now. So in 2019, there was a consensus paper that came out. The reference is there for you. And it was a group of physicians and clinicians working with pediatric feeding difficulties that really came together and formed a consensus statement, formed these different 4 domains. And this is actually now translated into ICD-11 codes. So as of October 1, we actually have new pediatric feeding disorder, PFD diagnosis codes, R codes, which is just very, very exciting for us in that world, because we actually have a way of coding a lot of what used to just be considered symptoms, but are actually functional deficits and disorders at this point in time. But I always like to start with this because it's just a nice holistic view of pediatric feeding disorders and all of the different areas that it can impact. So it does follow the ICF, the International Classification of Functioning, Disability, and Health, which if you look on ASHA's website too, they've really been pushing us over the last few years to look at ICF and even just how we write our goals and how we approach our therapy and our goals and all of that. So specifically for pediatric feeding disorders, PFD is how you'll often hear it called as well. The definition in the consensus statement is essentially it's defined as a disturbance in oral intake of nutrients, inappropriate for age, lasting for 2 weeks, and associated with one or more of these 4 areas. So it could be a medical etiology, it could be something nutritionally happening, psychosocial. So a lot of that family dynamic, what is happening that's disrupting the family dynamic, the psychosocial elements of that. And then of course, the feeding skill area as well. And in the feeding skill area specifically, I wanted to mention that actually breaks it down further into oral sensory, oral motor, and then the pharyngeal phases. So there are kind of further breakdowns. And so if we actually mapped the ICF, which is about function and disability and how we function with environmental factors, personal factors, all of that, and we map that onto pediatric feeding disorders, really its meal times occur as a result of the interaction between the child's body, their functions, their structures, their health conditions, and any other contextual factors that might be at play, like environmental challenges or environmental issues. It could be socioeconomic status, food security, just cultural differences, lots of different steps. So I just always like to start with this as kind of a grounding framework that everything that we kind of do builds from. And again, while this is pediatric specific, I really think all of these domains extend beyond pediatrics as well. So when we look at this picture, and this is something I really like this picture, and we're going to focus on these sensory components of feeding skill development and just meal times as a whole. And again, it's not just a pediatric thing. We all kind of look at these different trays. This was a picture that came out several years ago by Sweet Green, which is a health food company. And what they were trying to do in this picture, there was a lot of back and forth on social media and stuff too of the accuracy of some of these. But what they were trying to do is really simulate, this is just a sample of their pictures. They were trying to simulate what do school lunch cafeteria meals look like across the world. And they kind of created these trays, whether it's reality of not or not of what's actually served in those cafeterias. This was a simulation of the types of cuisines that were unique to each of these countries. And so things that you may actually see at a mealtime. And we can kind of look around this slide and, really look at just what a colorful in some countries array this is, a lot of textures, a lot of fragrances, smells, different just shapes and colors and all that kind of stuff. And then we start to look at some of them and, even more specifically at the US, a lot of brown, yellow, white, orange, maybe that touch of green peas or maybe green beans sometimes, a little bit of ketchup for some color. But typically a lot of our foods, and especially when the packaged food industry really kind of sprung up and moved forward, a lot of our early foods and then even long-term tend to be these more bland, they feel the same kind of texture-wise, breaded colors and foods and textures. So really mealtime and eating is a whole body, full-on sensory experience. And when we are limited with what we're exposed to for various reasons, or we have patients that are limited to what they are willing to do or able to do, it can be a breakdown. It can be a challenge. So I always just like to kind of start with this too, and just for us to start to think about, really, it's not just put it in your mouth, chew, swallow. There's so much more that goes into this. And also, some of you may look at this picture and say, oh, I would never eat that plate, or I would never touch that, or I would gag if I looked at this or put this in my mouth. And so just kind of keeping some of those emotions and feelings that might be coming up for you as well as you explore even just visually what these trays might look like. So if I showed you all this picture, a lot of us are seeing these pictures on social media. If you have kiddos of your own, you might be posting pictures of smash cakes for their first birthday. And, you know, we're very excited about these and we post them, and we even, you know, might be paying professional photographers to get these pictures and capture them beautifully and perfectly, and just such a milestone. And we're really enjoying all of that. But if we, there we go. If we saw a picture like this, or this was our experience in our house, many of us cringe, or we might be wiping, or we're like, oh my gosh, that's too messy for me. So I wanted to kind of put these side by side, just to, again, just pause and reflect, and you know, just trigger some thinking of, why are we okay with certain messy food experiences, and why are we not okay with other messy food experiences that may actually even be more functional in nature? And a lot of this, again, is I think just our culture and where we're at, and what we think or have learned to think is acceptable and what isn't. So just to review our senses, you know, these are the 5 senses that we typically talk about, that we're all familiar with: our vision, our sense of smell, our sense of taste, sense of hearing, and our sense of touch. But really, we have 8 senses. And so the ones that we often don't talk a lot about, and again, this is not just a pediatric thing, but one of our senses is our vestibular sensory system. And that is really our sense of balance, where we are in space. So when we, you know, do exercises, or we stand like this, kind of having that body awareness, a lot of this is related to our inner hair cells in our ears. And so if we have clogged ears, congestion, we tend to be kind of wobbly, dizzy. We don't have really a very strong sense of balance. For some of us, this might look like when we sit on those tall bar stools and pub stools, and we can't find a rung for our feet, and we're constantly kind of moving and dangling and just trying to find stability. That might be because our vestibular sense is actually challenged, and we need to know where we are in space. We're not just kind of wobbling and just moving without stability. The other sense is our sense of proprioception. And that is, again, if, you know, vestibular, I feel like we still have more awareness of, and we often will at least talk about it, but proprioception is not often talked about in our realm, at least as speech pathologists. And so proprioception is, again, another, and proprioception and vestibular can often kind of go hand in hand, but it is, again, our sense of body awareness, but also our sense of kind of where our joints are in space. And so this would be when you go to the pediatrician's office, or you go to your PCP and they say, close your eyes, touch your nose, and you know exactly where to go. Or you raise one hand and you have your eyes closed and you have to match the other hand with it. That's because you have joint awareness of where things should be in space. So vestibular is balance, and proprioception is knowing where you are and just how those joints move. And so for a lot of our preemies, this is something that they struggle with, because how you build your proprioception is through just joint awareness, which is through joint compression, that extension and flexion that happens in the womb. So when they come out early and they haven't gotten those messages, this is one of the areas they can struggle. And so proprioception might also look like some of us that really need a heavy sweatshirt to know kind of where we're at, or to feel comfortable, or even having a heavy blanket over us. So these are all things that we are catering to our sensory system to regulate ourselves. And then finally, this is a newer sense, so to speak, but very, very critical for us in the feeding and swallowing realm, and just the healthcare in general, is the sense of interoception. And that is basically it's internal. So everything else is very external, right? Like you touch something externally, you see something externally, you balance externally, even though, yes, in your internal body is driving awareness of that, but they are responses to external stimulation. Interoception is the only one that is internal. So that is our fight or flight, our appetite, our sense of hunger, our nausea when we see something and we kind of retch or we like want to throw up. Those are all coming internally. They're very visceral reactions. And so this can often be a huge area of breakdown for our patients because sometimes, again, whether peds or adults, whichever one, think about an individual that's been on prolonged tube feedings, for example, or a continuous feeding where their stomach really hasn't learned the sense of hunger because it's just been slow drips all day long. So this would be an individual that would probably struggle to really tell you that they are hungry, to really cue for something, to ask for something, to then also feel full because their internal body organs have not learned how to actually regulate that input. So when we think of our senses, then what really is sensory processing disorder, or SPD? And it's really, there's a lot of research still going on. They haven't really pinpointed exactly what causes it, but the general thought process is that it is a neurological condition, and it is caused by our nervous system and our nervous system's inability to interpret all of the senses and all of the sensory information that's coming at us. And so it's kind of like this traffic jam. So ideally, the sensory input comes in, we process it, our body processes it, our brain processes it, and then we kind of separate as this is okay, this is not okay. And this is kind of that middle. All right, I can tolerate this. This is kind of an equilibrium. But when we have a sensory processing disorder, all of those blue lines and arrows are not as clean. It's essentially a traffic jam. It's a mumble jumble. Things are going all over the place. Our nervous system is firing kind of out of control. And we take in those messages, we convert them into motor and behavior responses, but they don't really get organized into appropriate responses. And so we're just kind of really a whole messy kind of state of affairs, which is then really what's called sensory processing. So, there's a lot of research in the occupational therapy realm, especially on this whole concept of sensory processing, the sensory traffic jam that just makes it really, really difficult to coordinate and organize all of these things. And because of this, everyday tasks become a challenge. So one point I always make is we all as humans have sensory preferences. So that might, again, look like some of us need a certain temperature to fall asleep or a certain temperature just to function well. We might need our coffee to be a certain temperature in a certain cup because it feels a certain way with this particular straw. We might be really annoyed by that hole in our sock because it just feels funny and your toe is just not happy about it. But can we move on? Can we compensate? Can we continue to function without breakdown? And if the answer to that is yes, then it's typically not a sensory processing disorder. But when it starts to impact function, when it's breaking down your activities of daily living, you're just really not able to move on and process and function. That is when it starts to become really that category of sensory processing disorders versus a sensory processing preference or a sensory preference. So just again, something to keep in mind, because some of these things might look like, oh, why is the child having a meltdown? Must be a behavior thing. But is it happening so much that it's really disrupting that psychosocial element of that family dynamic where they maybe can't go out to a restaurant because it's too overwhelming for them? Then that is where there is breakdown in skill and function happening. So again, what does this have to do with feeding, right? So, we know it's just an important biological function. It forms an integral part of, I'm just going to click through these so they're up there. There we go. It's a really, like, feeding and meal times are just such an integral part of that family structure. It's part of how we socialize. It's how we celebrate. It's how we mourn. A lot of what we do, almost everything we do, really involves feeding and swallowing and meal times and just, all that food prep that's around it. And so it also is an opportunity across the age spectrum to really practice those motor skills, to develop communication, our cognitive linguistic things, social emotional development. There's a lot that happens really just around meal times. And in the pediatric side, learning to eat is also kind of following our motor milestones, our sensory development, our visual development, our physical development, all those areas as well. So they're all kind of moving hand in hand. And then the process of really having sensory experiences or allowing yourself to have those experiences is, again, really based around trust. We have to trust something to allow it to then actually happen. So if it's someone that's had prolonged intubation, or like a pediatric or adult again, but especially an infant that maybe was intubated for a long time in those really critical periods of development, have they built an aversion? Have they built an interoception, a sense of mistrust in what is this going to feel like once it goes inside of my body, because I had something inside of my body that maybe didn't feel good, or I had a ton of reflux, and every time I swallowed, I threw up, and now I've developed this sense of fear that I don't really trust that anything I touch or play or put my mouth on is going to feel pleasurable. So that is really where sensory processing really comes into play in all of these aspects. I always say it's not just about putting it in your mouth, chewing and swallowing. There's so much more that goes into it. And so it's also sometimes been called sensory integration dysfunction, but sensory processing disorder, SPD, is really kind of the term that's used a lot more right now. And that's essentially, again, like I've been saying, there's a sensory input that comes in, those receptors are stimulated. We organize and process all of that. We interpret it, we store it. And a lot of this, again, is related to our previous experience, right? So if, for example, if we've eaten something and we didn't feel good and we felt sick, we've interpreted that, we've encoded that, we've stored it for later. And so that can then become that experience where we're like, I'm not quite even gonna want to smell that food. I look at that picture, I might be like, I don't want to do that because last time I did that, it made me throw up. And then we actually have a response that's generated. Sensory processing difficulties can affect about 16% of school agers in the US. So if you are a provider that's working in the school system, this might be something that you're seeing a lot, thinking about even the cafeteria and meal times over there, and how some of our children might actually have some real difficulty functioning in that environment. So again, feeding and eating just is not just about putting food in your mouth, chewing and swallowing. It's all of these things. When you take a bite of a blueberry or a green bean or a chip, you're tasting it, you're crunching it, you're hearing the sound of that crunch, you're popping something that juice comes out of. There might be a squeak in your on your teeth as you're chewing. So there is just so much that happens around the whole eating, feeding, mealtime process that really just is way more than the actual physical skill of taking something, putting it in your mouth, and then oral phase, pharyngeal phase, esophageal phase. There is a lot more that goes into this process, again, across the entire life spectrum. And so really, this is all of the stuff that mealtimes include. So we have to really be tolerant of even being in the presence of a particular food. So again, many of us may have this experience where just having something present on the same table, even if it's not on our plate or it's not even open, just visually having something may be a little bit of a challenge. So how can we actually be in the presence of that food and then actually be able to move forward in the mealtime? And then actually interacting with the food. So the example I often give is if we went to a new country or a new cuisine, or you were blindfolded and you had to try something, typically you're not going to just take it and put it in your mouth. You're going to kind of look at it a little bit, see if you want to trust it. You're going to maybe play with it. Then you're going to maybe smell it, see how appealing it is to you or not. Then you may actually venture into touching it once you're like, okay, maybe I trust this and willing to do a little bit more interaction. Then you're going to actually maybe take a small bite, taste it, a little dip, and then you're actually going to proceed into the mealtime. So again, we take so much of this for granted until there's breakdown somewhere. So this is, again, just steps that go into the entire mealtime and the entire process. And that's why mealtimes are just not about the actual skill. It's about everything else that's going on. Because again, we have so much sensory input that's coming our way that we really have to process and organize. And so this is just, I just kind of put this visual there of the same child kind of going through different stages. I mean, she looks like a pretty happy camper there, but all the different things that may involve feeding and meal times, which is why it can be quite a messy affair. And that's okay. Like pictures like this are a feeding therapist's dream come true when we see messy meal times, because we know that this means the sensory system is allowed to actually get that input. One of the things I share too is when children are developing and growing, they explore almost everything with their hands. They touch the grass, they play with the sand, they touch their toys, they might touch the walls, they're touching clothes, they're touching, feeling, playing with everything, and then taking it to their face, taking it to their mouth. The only place where as adults we tend to come in very quickly and deprive them even sometimes of these experiences is when it comes to feeding and eating, because again, we have been conditioned to clean and wipe and disinfect and all of these things around meal times. But historically, and in many cultures still, this is how meal times look. We touch, we feel, we have sensory receptors on our hands that tell us this is okay and this is not okay. And that's why we know when we touch something that's hot, oh, I need to back away. But if we never have those experiences, or we're constantly deprived of that, or things are wiped off of us and all we're smelling are those wipes or chemicals or, just things that are very medical, for lack of better words, we're depriving that brain, we're depriving that sensory system of experience that is needed to then build these skills later down the road. So this is, I just put this picture of, just two kids interacting with foods. It's a pretty, not quite overstimulating plate. It has similar shaped items, two different colors. They have some dipping that they can do. Just overall, less stimulating, even though this itself could be stimulating for some of our kids that have significant sensory processing. But just to kind of give you a visual of this and then this. So right now, especially with the holidays and the holiday season, a lot of our patients can often struggle with just navigating the space, and family members may be struggling with their kiddos if their kids have sensory processing difficulties, taking them to family events, or how are we going to navigate this, because we know they're going to have a meltdown, or they really need to just eat these 3 foods or this one thing off in a room by themselves and then come interact and do other things. And so just looking at this too, there is so much that's going on across all of our senses. Visually, I'm sure there's a lot of chatter. So auditorily, there's a lot going on. Smells, the clinking of silverware on the plate or serving, probably hands getting messy, even though they're all using their forks and knives in this picture. But just again, a lot that's happening that has to be navigated for really any of us. And sometimes we don't have sensory processing issues. And I'm someone that visually, I get very overstimulated with foods, because I grew up in a culture that was very much what was on your plate had to be completed. And it was a very overwhelming feeling for me. So till date, I always share this example, if my plate is very, very full, or I'm at a table that looked like this, I need to excuse myself, or I'll kind of find a quieter spot. And I might actually end up eating the same amount of food, but in little bits and pieces, because I can't have it all on my plate, because I will just completely lose my appetite and shut down. But I know how to navigate through that, and I don't break down emotionally and then kind of have a functional deficit as a part of it. So here are some just red flags that may signal a sensory processing challenge. And I want to make a point too that sensory processing disorders are often paired with autism spectrum disorders, but they don't have to be. They can be in isolation. So every child that has sensory processing doesn't automatically have ASD or autism spectrum disorders, but most children with autism spectrum disorders tend to have a lot of sensory processing. So just to keep that in mind. But these are, again, just some red flags that are out there. I'm not going to read all of them. They should be in your slides. Some of these, again, might look like this is just my normal kiddo that, can't sit or can't do this, or, leaves, or is having a meltdown, having a tantrum. But again, the frequency, the intensity, the disruption to everyday life, that is what you want to be thinking about and keeping in mind that something about that mealtime consistently looks, tastes, smells, sounds, or feels really uncomfortable and really overwhelming to where it's causing a behavioral response. And as communication specialists, we have to always remember that behavior is communication. So the child is trying to tell us something. So some things that, to keep in mind from a assessment and treatment consideration. The sensory system can be, again, very, very sensitive. It can be hyper or hypo, but typically you don't want to just go to the mouth or the face and start something when you're still trying to build trust with your patients. So we always recommend kind of starting outermost space. So maybe that looks like if you're doing food play, for example, or you're using a vibrating tool, or you're doing massages, you're trying to figure out where the kid's at with touch. You may want to start on their legs or their feet and then move up, and maybe their back or maybe their hands, and kind of work your way up to their face versus just going to their face right away. And they are like, stop, hold on, I can't do this. It's a lot of slow, systematic, repeated steps, and really considering all of the sensory system. So can they tolerate this? Can they touch it? Can they smell it? Like I was talking earlier. And it can take a lot of time. It could take 25 to 30 exposures each time, each food, to really build these kiddos up and really move through things. And what are all of these different varying degrees of complex interaction, like that pyramid of, touching, interacting, smelling, seeing? What does that look like? Sometimes I'll actually give parents that chart, and I'll say, just start tracking on here for all of your different foods. Maybe make it a fun activity, put some magnets that are food magnets that maybe you're like, hey, like today we touched this food, so we're here with the apple, and today we actually smelt our cucumber, so let's put it over here. So you can kind of make that as a way to track your goals as well, and also to give parents and children a way to interact and look at their progress at home. I'm going a little fast because I can see that I'm running out of time, but if you have the privilege of trying to really co-treat with a occupational therapist, they can help you with what's called sensory preparation or sensory diets, which looks like a lot of just sensory-based activities to get the body organized before actually interacting and participating in the task that is actually challenging for the child. And then really, again, we are communication specialists, we are speech language pathologists. So using that cognitive linguistic language play ability to really look at what the child can do. Can they count their foods? Can they sort by color? Those are all interactions as well. It doesn't have to be bite, chew, swallow. Again, it doesn't have to be meal prep, but can we include them in activities that continue to expose them to these foods? Again, something as simple as grocery shopping, where they're labeling and pointing out foods and touching textures, can be a really good sensory diet activity for a lot of our children. And then what's our packaging consideration? So if we have a child that's really particular and all of a sudden McDonald's changed what their chicken nugget shape looked like or what their packaging looked like, is that going to really cause a lot of breakdown for our child? And how do we plan ahead for that and work through that process, desensitizing them a little bit or acclimatizing them a little bit to what changes may come? And that's where this concept of food chaining can come in, which is I'm actually going to skip to that in a second. These were just a lot of examples of different sensory activities that you can do. So I'm not going to go into too much detail, but just different ways that children may need to, as long, even like a high chair, having support for those feet so you're not dangling vestibular support over there, playing with food, making ice cubes with them, food coloring, food dye, adding one Cheerio at a time to change, what those textures and colors can look like. Meal prep, the vestibular swings, and just some activities that OTs can really help us with. Weighted lap pads, sensory tools like that, yoga, bear crawl. These are all like sensory processing and feeding can be like an 8-hour lecture in itself. So this is just giving you a glimpse into that world. But this is what an example of food chaining could look like, which is basically you're changing one characteristic of a food at a time to bridge from start to finish. So your goal may be, I want this child, or the parent's goal is, I want my child to eat a peanut butter and jelly sandwich. And maybe they already love strawberries. And so how do you change one thing at a time, which even on this screen, going from a whole strawberry to slices and jelly and bread may be too much for a child. But how do you take that, go to the next step, move on down to maybe just jelly. Maybe you're dipping it in peanut butter, you do a half and half, and you're slowly building what that is. And every step of this could be broken down even further depending on your child and depending on what their needs are. And you're going to be going back and forth. So I always say, this is just another example of that. Sensory processing is really, once you find that code that lets that kiddo tick, it's really, really miraculous, but finding that sometimes takes a lot of patience and a lot of just work back and forth. So really just, again, keeping a lot of these pieces in mind. If you are working through food chaining or really adding foods into your child's diet, really just keep in mind again that nutrition is still that most critical piece. So if we're spending months and months and weeks working on, hey, let's get them to eat this pretzel stick that really doesn't have a lot of calories, could we maybe redirect that focus into something that does give them calories, that is more nutritious, that really just balances all of what they need to grow and develop as well. Considering all of those sensory systems, some of our kids are on some specialized diets. And so getting to know that and understanding that and how that can impact their behavior as well. This is that bite-sized chart I was talking about in a previous slide. It is available for free on that website through Marcia Duncline, who's a fabulous OT. But this is a way, again, to build trust and to build what those sensory experiences might be and what those bite sizes might look like to even try and touch and lick and smell. Casey, I know I'm over by a few minutes. Do I have time to play this video?
Yeah, if you want to play it really quick.
Yeah, I'll play just this one. But I mean, that was, again, a very, very quick, really overview of the sensory system and how it impacts us and considerations to keep in mind across the spectrum of disorders. But I really just wanted to play a very quick video for you guys of just what life in the day of a child with sensory processing looks like. It's just a 1-minute video.
I choose my favorite soft clothes without tags. I can't grasp the zipper to my sweatshirt, so mom helps me. I have plain toast for breakfast. Mom cuts strawberries, but I don't like the small seeds. During group work, my teacher tells me to pay attention. The other students are talking and moving so much. I cannot concentrate. The lunchroom is so loud. I feel anxious and put on my headphones. I try to eat my lunch, but the smells in the lunchroom make me gag. I'm doing my homework when my little brother starts to cry. I yell at my brother to stop crying. My mom sends me to my room. It's hard to find a comfortable spot in bed. My mind is so busy. I can't fall asleep. My mom covers me with a heavy blanket, and I finally drift off. If your child experiences sensory processing struggles, Brain Balance can help. Visit Brain Balance.
All right, so no endorsement to that Brain Balance.
.com and discover.
But I just wanted to show that video. I'm going to skip this one in the interest of time. But that was a very quick, speedy version again. I'll be happy to answer any questions that are in the chat and all of that. So please feel free to reach out if there's more information or you need any specific details in any of the very quick techniques that you either saw me talk about or are on your handouts. Thank you.
Thank you so much, Ramya. So this concludes our first night of the summit. Please come back and join us tomorrow, the same time, for 4 more presentations. Have a good night, everyone. And thank you so much to all our speakers.